Anatomy 1, Chapter 9, Articulations. So joints, also known as articulations, are defined as where two bones come together. Movement can occur at joints, but one thing we have to get used to is the idea that joints don't always move. Notice that the official definition of a joint or articulation is where two bones come together or meet. So there are some bones or some joints that will not have movement. There are some that will have slight movement, and there are some that have free movement, like the joints you would usually think of: hips, shoulders, knees, wrists, ankles. A trade-off exists between strength and mobility. So we're going to find that the stronger the joint, the less it's going to move. So there's two big, broad classifications of joints: structural, which is the anatomy, and functional, which is the range of motion. The structure of the joint is going to determine the function of the joint. We can break joints up into some classifications according to those structures. We have fibrous joints, and these are going to connect by fibers. Cartilaginous joints, which will connect by cartilage. Bony joints, which are bony fusions. And synovial joints, which are going to be lined with a synovial membrane. The functional classifications there are three big ones: synarthroses, which are immovable joints, so no movement whatsoever. Amphiarthroses, these are in between the slightly movable joints. And diarthrosis, which is a freely movable joint. So we're going to go through each one and give examples of each. Then we'll have a summary figure that will kind of tie all this together in a nice little chart. So beginning with the synarthrosis, this is our immovable joint. These are very, very tough. In these, the edges of bone come together or interlock. They can be found to be either fibrous, which means they're attached by fibers, or cartilaginous, where they're attached by cartilage. There are four main types that fit in the category of synarthrosis: suture, gomphosis, synchondrosis, and synostosis. So let's start first with the suture and the gomphosis. So suture, which is again a type of that umbrella category, synarthrosis, which is the immovable type of joint, is found between the bones of the skull. So by now you've probably had a skull lab where you had to learn the names of the main sutures. These sutures, as you studied them in lab, you probably noticed that they do not move. These are places where the bones come together. The edges of these bones interlock and are bound by very dense fibrous connective tissue. So this is an example of an immovable joint that is connected by fibers. The suture joints are not for movement, they are for protection. We want our brain to be protected. The gomphosis is the union between the teeth and the jaw. So the teeth are bound to bony sockets, and they are connected by fibers, which is the periodontal ligament. So that ligament holds the tooth anchored into the jaw. And as you would agree, the teeth do not wiggle unless we're going to lose one. So this would be an example of an immovable fibrous synarthrosis. So in this figure, we can see our sutures, which clearly do not move. That's an example that we just went over. And then the gomphoses are the union between the tooth and jaw, which also do not move typically unless we're losing a tooth. So the synarthrosis continued. We have a synchondrosis, and the synchondrosis is an immovable joint that is connected by cartilage. So it's going to have a rigid cartilaginous bridge between two bones, or two parts of bone. Some examples would be the vertebrosternal ribs and the sternum, so where the rib joins with the sternum, and also the epiphyseal cartilage of long bones that are still growing. So if you recall from chapter 6, we talked about the epiphyseal cartilage and growth plate, and this would be where where it shows in an x-ray that we're still growing, that's cartilage there. So that would be a synchondrosis. A synostosis is created when bones fuse together. And some examples of this would be the mitopic suture of the frontal bone, which fuses in most, and epiphyseal lines of mature long bones. So if you are an adult and have stopped growing, or you've finished growing and you're not quite an adult, you may have epiphyseal lines where your growth plates have sealed. And those would be examples of synostoses. So here is the example of a synostosis, the mitopic suture. So this is an infant skull, and you can see where the frontal bone is in two pieces, and it joins at the mitopic suture. And when these bones fuse together, you can sometimes see a trace of where that suture was that has now been totally fused. So synostosis, fusion of bone. Here is the growth plate in someone who's still growing. This is the femur and the tibia. And you can see a dark space in the x-ray of where the cartilage is. So epiphyseal cartilage, which is a bridge of bone. So that would be a synchondrosis. And then when it fuses to leave an epiphyseal line, because this is now an adult, this would be a synostosis, or fusion of bone. So the amphiarthroses are the middle category. These are slightly movable, so not overly movable, but they do move some. They're more movable than the synarthrosis, stronger than the diarthrosis, which we're going to talk about next. And they can be fibrous or cartilaginous as well. There are two main types of amphiarthroses. A syndesmosis, which is where bones connect with a ligament, or a symphysis, which is when bones connect by a pad of fibrocartilage. So let's take a look at that in visual here. So we're looking at the posterior view of the leg or the ankle, and you can see the heel here. You can see the tibia and the fibula. There is a large ligament here connecting the fibula to the tibia. That's an example of a syndesmosis. So while you can't throw your fibula out to the side, you are going to see a little movement in it as we walk. So slight movement, nothing dramatic. Then we have the pelvis here. And in between the two os coxa bones, there is a disc of fibrocartilage called the pubic symphysis. And this particular symphysis is anchoring the os coxa bones together, but it is able to expand during childbirth, and it will give a little in mobility. So slight movement, but nothing dramatic. So that brings me to our final category, which are the synovial joints. Synovial joints are also known as the diarthroses. They are freely movable. So these are the ones that move a lot. And these are also the ones that we think about most when we think about the body. They're found at the ends of long bones, and they are typically going to be surrounded by an articular or joint capsule, which I will show you in a picture coming up here in just a second. They have a synovial membrane that helps to produce fluid that will lubricate the joint space. A special cartilage called articular cartilage, which we also mentioned back in Chapter 6, will cover the surfaces of the bones so that the bones do not rub together within the joint. So before we go over the details of what is in a diarthrotic joint, let's look at a summary figure taken from my study guide. So I like this summary figure because it kind of lays out everything we just talked about on one page. And for me, it helps to compartmentalize all of this so that it's a little easier to see the flow. So feel free to screenshot and use this as a study tool. So articulations or joints. We have three categories. Synarthroses, these are immovable. Amphiarthroses, slightly movable. And diarthroses, freely movable. Going back to the synarthroses, we said that there were three ways that we could find the synarthroses. First, we have fibrous. These are fibrous connections. The example that we gave was the suture of the skull and the gomphosis between the tooth and jaw. So those were connected by fibers and did not move. Next we have the cartilaginous, which was connected by a bridge of cartilage. Our one example was a synchondrosis, like the epiphyseal cartilage or growth plate. Then we had the bony fusions, and this is when bones fuse or pieces of bone fuse, and an example was the epiphyseal line, so after you finish growing. So the summary statement at the bottom of this column is that these guys are very strong, but they are the least movable. Okay, in the middle we had the amphiarthroses, which could be fibrous or cartilaginous. The fibrous example we talked about was the syndesmosis, connection between the tibia and fibula. So a little bit of movement, but nothing dramatic. The cartilaginous example, where we had a cartilage pad between two bones, was the symphysis, like the pubic symphysis. This category is strong. Notice we don't have the word extremely anymore. Strong, but more movable. And finally, we just moved into the diarthroses. These are freely movable joints. There's only one category, synovial. And the synovial joints are, again, lined by a synovial membrane, which produces synovial fluid. These are the ones we think about most often, like knees, hips, and elbows. And the synovial joints can be classified on their range of motion, which we're going to get to later on in the notes. But a monaxial joint, mono meaning one, is going to move in one plane of motion, like your elbow. And if you practice with your elbow, you can see that it is a hinge, and we can really only move it in one motion, a hinge motion, up and down. And then biaxial is two planes of motion, like the wrist. So if you practice with your wrist, you can move your wrist a little bit more than you can your elbow. Triaxial, three planes of motion, like the hip. So this category, you can see, is considered weak compared to the other two, but it is the most movable. So if you notice, in order to gain movement being the most over here, we had to compromise our strength. So strength is compromised for motion. The more movable we are, the less strong the joint is, the more liable we are to injure it. Okay, so let's focus in on the parts of a synovial joint because the rest of the chapter is going to focus pretty hard on synovial joints. We're going to see that synovial joints have, again, a joint capsule, which is what this blue area is here, also known as the fibrous capsule. The fibrous capsule is going to be lined with a synovial membrane, which we can see here in red. The synovial membrane will produce synovial fluid, which is going to fill the joint space. We'll also see on the surface of bone a thin, shiny, and smooth cartilage called articular cartilage, and that is the cartilage that prevents bone-on-bone rubbing. So we can get more detailed with the parts of a synovial or diarthrosis joint with some specific features that you will find in many of the joints. This is a knee. To orient you, we have the femur here, tibia or shin bone here, and here is the patella or kneecap. So you're looking at a mid-sagittal section right through the knee, this being the front of the body or anterior, and this being posterior. So let's talk about some of the features and we'll go back and forth between this picture and the notes. Synovial fluid that fills the joint space has the consistency of egg yolk, so it's not really watery and it's not really gelatinous, it's kind of in the middle. And it's mainly going to serve to lubricate, distribute nutrients, and also absorb shock. Synovial joints are mobile, but relatively weak. We talked about that in our summary chart. They do have some stability because of some of their accessory structures like cartilage and fat pads, ligaments, tendons, and bursae. So let's go through what those are and then we'll refer back to our original figure. So a cartilage that is common and very tough is called the meniscus, which is a pad of fibrocartilage bound between opposing bones. We also see fat pads, which are adipose tissue covered by synovial membrane, and it also serves to protect the articular cartilage in the joint. We'll find ligaments that will support and strengthen the joint. Sometimes you may have heard about someone getting or having a sprain, which is essentially when ligaments have torn collagen fibers in them, and that can cause pain and soreness within the joint. So let's go back and locate those three things in our picture. So here's our articular cartilage we talked about, and then in between the articular surface of the femur and tibia, you can see this thick pad here of cartilage. You can see a piece of it here and a piece of it here. That is the meniscus. So a very thick, tough pad of cartilage. Then we can see the fat pad. There's one right here in the front, and that you can see that's cushioning the joint opening here. And then we've got specific ligaments that are going to have different names based on where we are, what joint we're looking at. So here's a ligament here, and here's another ligament here. Okay, so we're also going to have tendons, which attach to muscles around the joint, and bursae, which bursa being one, is small pockets of synovial fluid. They are going to cushion areas where tendons and ligaments might rub against other tissues. So let's take a look at those to see if we can figure out where we're going to find them. Okay, so here is a tendon, and then here is a bursa. So we've got one there. You can see a couple more here as well, and there's one back here. Okay, so some other factors that stabilize synovial joints and prevent injury by limiting range of motion: collagen fibers of the joint capsule and the ligaments, the shape of the surfaces of the joint and the menisci, so that would be more than one meniscus, other bones, muscles, and fat pads, and tendons attached to the bones of articulation. So all of these things can help to stabilize the joint, even though we consider them relatively weak in comparison to the other types of joints. So the movements are described in terms that reflect the plane or direction of movement and the relationship between structures. So planes of movement are pretty simple. Monaxial, as I mentioned before, one plane of motion, your elbow. So if you extend your arm out straight, you can then bring your hand towards your face by bending your elbow like a hinge. That's monaxial, or one plane. If you have your hand out straight in the anatomical position, your wrist is an example of a biaxial joint because you can bend your wrist back with your fingers towards the posterior, or you can bend your fingers forward towards the anterior surface. Triaxial is three planes of motion, like your shoulder. So with your shoulder, you can put your arm straight ahead of you in the anterior position. You could put it out laterally or towards the side. You could put it posteriorly or towards the back. You can raise it straight over your head, and you can point your hands down straight at your feet. And you can make a big circle with your shoulder. So a lot more motion in the shoulder than we have in the other two examples. Types of movement at the synovial joints. So we can have a gliding movement, angular movements, circumduction, rotational movements, and special movements. So we're going to look at examples of all of those in that list. So here's the shoulder, which is the most movable joint in the body. Again, a joint that permits movement on one axis or around one axis is called monaxial, like the elbow. A joint that permits movement around two axes is called biaxial, like the wrist. And three would be triaxial, like the shoulder. So a gliding movement is what it sounds like. This is when two flat surfaces slide past each other. An example would be your carpal bones. So those would be the bones of your wrist. Those are going to slide past one another during wrist movement. Angular motion includes flexion, extension, and hyperextension. So how can we tell the difference between the three? Well, first you want to picture the body in anatomical position. When you are in anatomical position, most of your joints are going to be at extension. Okay? So if we look at this figure here, if you focus on the woman, or the view of the woman where she's standing straight in anatomical position. So most of her joints are at extension. Okay, see how the arm is nice and straight and the hip to the foot nice and straight? So that's extension. Okay, and flexion is when we decrease the angle between the articulating bones. So if you're standing in anatomical position and you bring your hand up towards your face, like we can see right here, that is flexion. If you're standing in anatomical position and you bring your foot up towards your face, flexion. Here's the wrist, bringing the wrist around towards the face, flexion. So flexion, we decrease the angle, and extension, we increase the angle. We straightened out to anatomical position. Hyperextension is extension past the anatomical position. And not every joint can do that. So here's our elbow at extension. Can we hyperextend our elbow? In other words, can we bring our forearm back to here? Absolutely not. This is a monaxial joint. It will only flex and extend. But if we're talking about our hip, and this is extension, can we bring our leg back past the anatomical position? Absolutely. That's hyperextension. Same thing with the wrist. This is flexion. Going straight up and down right here would be extension. So if we bend our wrist back past anatomical position, we can do that. That's hyperextension. So again, past anatomical position. Angular movement includes abduction and adduction. These are movements in the frontal plane. Abduction is to move away from your center or longitudinal axis. I like to think of it as the midline. And also, the word abduct is in abduction. So to abduct is to take away from, and I like to think of it as take away from home, which is kind of depressing when you think about an abduction. But if you think about in anatomical position, your hands, your arms are close to home, which is your midline. If you bring your arms out to the sides, like we can see her doing here, so this is taking your arm from anatomical position and moving it out to the side, that's abduction. You're taking it away from home or midline. Now, if we bring that hand back to anatomical position, or right here, that's adduction. Add, I like to think of it as adding the arm back to home, bringing it back. Adduction, movement toward the midline or longitudinal axis. So here's the hand. Abduction, all the fingers have spread out. Adduction, bringing them all back together. Circumduction is a complete circular movement without rotation. So what do we mean by that? Well, that's something we can do with our very movable shoulder. So you can see that this person has her arm straight out. She is not rotating it, but she's rotating or she's moving the shoulder joint, and she's able to make a full circle without actually rotating the arm. That's a circular movement without rotation, known as circumduction. Rotational movement. So rotational movement, and this is always going to be in reference to anatomical position. So if you're in anatomical position and you look to the left or right, you are rotating your head. Limb rotation is relative to the longitudinal axis of the body, or your midline again. So medial rotation is an internal rotation toward the long axis. Lateral rotation is external rotation away from the body. So let's take a look at what that actually means. So in this picture, looking from left to right is head rotation. So here's the arm, lateral external rotation, and if we fold that hand over, that's called medial internal rotation. So open it back up again, lateral external rotation, roll it back over, medial internal rotation. So under the rotational movement umbrella, we still have pronation and supination. So pronation is when we rotate our forearm so that the radius rolls across the ulna where the palm is facing posteriorly. So we would be starting in the anatomical position, and then rotating our forearm so that the radius goes across the ulna and our palm is now facing posterior or towards the back. Supination is turning the palm anteriorly or towards the front. When you stand in the anatomical position, your forearm is supinated. So looking at this figure here, this guy is standing with his palms forward. That would be anatomical position, supination. And if we roll it over, that's pronation. You can see where the radius crosses over the ulna and the palm is facing back. Some other special movements include movements of the foot. So inversion is when we twist the sole of our foot medially or towards the midline. Eversion, twisting the sole of the foot laterally or away from the midline. Dorsiflexion, lifting your toes. So that would be pointing your toes towards your face. And plantar flexion is extension at your ankle or pointing your toes, like when you would stand on tiptoes. So inversion, pointing the toe toward the midline. Eversion, pointing the toe away from the midline. Dorsiflexion, pointing toe towards the face. Plantar flexion, standing on tiptoes or pointing the toe downward. Some other movements including the thumb and also using the jaw as an example too. So opposition is the movement of the thumb toward the palm or other fingers. So this is where we get the phrase opposable thumb from. And reposition is the opposite of opposition. So let's look at those. So here's opposition, taking your thumb and folding it across the palm. Protraction is an anterior movement in a horizontal plane. So if we're talking about the jaw, this would be to jut the jaw forward. So protraction, to jut the jaw forward, give yourself an underbite. Retraction would be the opposite of protraction, to pull back. So if we're talking about the jaw, to pull the jaw back in again would be retraction. Depression is to move a structure down. So to drop your jaw would be depression. Elevation is to raise a structure superiorly or up. So to raise your jaw back up would be elevation. Lateral flexion is to bend the vertebral column to the side. So if you try to lay your head on your own shoulder, that would be an example of lateral flexion. So here's depression, dropping the jaw. Raising it, elevation. Lateral flexion, to lay your head towards your shoulder. Movements at synovial joints. So classification of synovial joints can be plane or gliding, hinge, condylar or ellipsoid, saddle, pivot, ball and socket. So let's visit each one of these, starting with the plane. So a plane joint or gliding joint is flattened or maybe slightly curved. There's very limited motion. A hinge joint is an angular motion in one plane, monaxial, like we talked about the elbow. Condylar joint is a joint where there is an oval articular face within a depression. Motion in two planes, biaxial. So let's look at these in a picture to make them a bit more clear. So here's a plane joint. And we've got a mechanical example and an actual example. So the mechanical example, you can see it's two flat surfaces gliding past one another, which is why it's sometimes called a gliding joint. There's not a lot of movement. We can also see this between the sternum or breastbone and the clavicle. So if you lift your shoulder up and back down again, your clavicle will do a little bit of gliding across the sternum, but again, it's nothing dramatic. A hinge joint is like it sounds, a hinge. Open and close, like the elbow. The knee would be another great example of a hinge joint. A condylar joint is where we have one bone that has a convex or rounded end that pops into an oval depression of another bone. So a good example of this would be the scaphoid bone of the carpals or wrist and how it nestles snugly right into the concave end of the radius. Condylar joint, also known as ellipsoid. We've then got the saddle joint, pivot joint, and ball and socket to finish up. Saddle joint is where one bone sits on another like a person would sit on a saddle. These are typically biaxial. Pivot joint rotates only and is monaxial. And a ball and socket is where we have one bone with a round head in a cup-shaped socket or depression. These are triaxial. So here's our saddle. You can see where one bone would sit on another bone, like a person sits on a saddle. A great example of this is the first metacarpal bone of the thumb sitting on the trapezium of the carpal bones, and it does sit on the trapezium like a person would sit on a saddle. Pivot joints only allow rotation. Great example of this are the first two vertebrae in your vertebral column, C1 and C2, also known as the atlas and axis. So their orientation allows you to look from left to right, simple rotation. Finally, we have the ball and socket joint, which is a bone with a round head that fits into a socket. And because of this orientation, we get triaxial movement like we see in the shoulder and also in the hip. So these are our most movable kind of joints. Okay, so focusing in on some specific joints. The vertebrae, in between the vertebrae, we have intervertebral discs that separate the individual vertebral bodies. These discs are made up of two main parts. The annulus fibrosus, which is the outer part made up of fibrocartilage and is very, very tough. The nucleus pulposus is the soft, elastic, gelatinous core of that intervertebral disc, and its job is to absorb shock. So here's a picture of the vertebral column. And we can see in between the individual vertebrae, so here would be 1, 2, 3, 4, 5. You can see the intervertebral disc in between those vertebrae. And we've got a soft, squishy core called the nucleus pulposus and a tough outer fibrocartilage around the squishy core called the annulus fibrosus. The elbow joint, again, is a hinge joint, which means it's monaxial, and the articulation or joint involves the humerus, which is the upper arm bone, and the bones of the forearm, the radius and ulna. So at the elbow, we see the humero-ulnar joint, which is where the ulna joins to the humerus. This is the largest, strongest joint at the elbow. Very limited movement. Remember, we're just monaxial. Humero-radial joint. is where the humerus comes together with the radius. This is a smaller attachment. So here's our humerus coming down, and then here's the connection with the humerus and the radius, and then the connection with the ulna and the radius. The knee joint is a complex hinge joint too, and its job is to transfer weight from the femur to the tibia, which is your shin area. There are 3 connections here, 3 articulations within that joint. 2 between the femur and tibia at the medial and lateral condyles. So if you've started working on your appendicular lab, then you know exactly what I'm talking about when I mention those condyles. But if not, I'll point them out to you in just a second. And also 1 between the patella and the patellar surface of the femur. So in the joint capsule and joint cavity of the knee, we have a medial and lateral menisci. Fibrocartilage pads are what the menisci are made out of at the femur-tibia articulations, and they will cushion and stabilize the joint. This is going to help us to avoid bone-on-bone contact. So in this figure, we can't really see the condyle, so I will show you that in the next figure, but what I want to point out is here's our patella, which is the kneecap, and where it joins to the femur. So right underneath this kneecap is the patellar surface on the femur. You can see the fat pad underneath the patella as well, and there's lots of ligaments here to strengthen up that knee joint. Alright, so in this figure, here's our patellar surface, which is where the patella would lie. And then we have a union between the tibia and the femurs at the lateral condyle, which is this knobby end of the bone, and the medial condyle, which is this knobby end of the femur. And underneath each condyle, we can see the menisci. So here's the lateral and medial. That's that thick pad of fibrocartilage that prevents bone-on-bone rubbing in this joint. The shoulder joint, also known as the glenohumeral joint, is a ball and socket diarthrosis between the head of the humerus and the glenoid cavity of the scapula, which would be the socket. It has the greatest range of motion of any joint, and it's the most frequently dislocated joint. Remember, the more movement we have, the weaker the joint is because it can't be bound down by lots of connective tissues and fibers. So it's free to move, it's also free to hurt. It's supported by skeletal muscle, tendons, and ligaments. So here's a view from the front of the shoulder, and you can see the humerus right here. This represents the scapula or shoulder blade, and the socket in the scapula, called the glenoid cavity. The head of the humerus pops into that socket to form a triaxial joint. So here we're looking laterally or head-on at the joint, and you can see this nice smooth glenoid cavity where again the humerus would pop right in. Hip joint between the head of the femur and the acetabulum of the hip bone. It's a strong ball and socket diarthrosis. It is triaxial and has a very wide range of motion. So here's the hip bone or os coxa, and this is the socket, the acetabulum. This is where the femur would insert into the acetabulum. Okay, so to finish up the chapter, we have some effects of aging on the joints. Degenerative changes over time include rheumatism, which is general pain and stiffness in your musculoskeletal system. Arthritis is joint inflammation. So any rheumatic disease that affects your synovial joints is considered arthritis. Osteoarthritis in particular is caused by wear and tear of joint surfaces, which can be because of use over time, or it can be genetic factors that affect the ability to make collagen. Generally affects people over the age of 60. Rheumatoid arthritis is an inflammatory condition where the immune system attacks the joints. And gouty arthritis is when crystals of uric acid form within the synovial fluid in the joint, which can cause really severe pain and swelling within the joint. As we age, our bone mass decreases, bones weaken, and the risk of fracture increases. There are other systems that interact with the skeletal system. We're getting ready to head into the muscular system next. Muscles attached to bones. Bones are controlled by the endocrine system. Digestive and urinary systems help provide calcium and phosphate so that we can have enough of those things for our bones to grow. And the skeleton is a rich reserve for calcium, phosphate, and other minerals that we store in the skeleton. So this figure shows the interaction of the skeletal system with other body systems. So in the integument, we know that we talked about how we're able to absorb vitamin D3, and that helps us to better absorb calcium in the gut by receiving ultraviolet light through the skin. Skeletal system provides structural support for the skin, and it also performs several major functions for the human body. So we know that it gives us support, stores minerals and calcium, as we mentioned, lipids in the form of yellow bone marrow. It also forms blood cells in red bone marrow, protects our soft tissues, and gives us leverage for muscles. So that concludes Chapter 9 on articulations or joints, and we will meet again in Chapter 10, where we will go over muscular tissue and contraction.